Hello, friends. I'll be talking on this topic which came in Chest Journal in 2022 January, titled "Focused Management of Patients with Severe Acute Brain Injury and ARDS." So this is a good sort of a top overview that came in this article, and I would urge all the trainees to go through this. So it would be useful from their clinical standpoint and from their knowledge standpoint, because many a times we would deal with a situation where a traumatic brain injury do have concurrent ARDS. It may be secondary to infection, or it can be due to the lung contusion they can develop ARDS. So it is good to have an overview as to what are all the safe sort of a methodology that one needs to adopt whilst managing ARDS along with traumatic brain injury. So in severe acute brain injury, so one of the common problem that we see is increase in the ICP, and along with increase in the intracranial pressure, the intravascular pressure also can be high in these patients, and this is shown to cause damage of the alveolar capillary membrane. So this particular barrier between the capillaries and the alveoli gets breached, and there can be endothelial injury due to the inflammatory response and due to the increase in the intravascular pressure. And there is a sort of a cytokine activation that happens within the brain tissue because of the whatever acute brain injuries they would have sustained. And because there is a sort of a cytokine storm that happens within the brain, there is release of a lot of these cytokine mediators like interleukin 1, 6, 8, human necrosis factor alpha. All this gets released. So very often, I'm sure many listeners would appreciate that initially following traumatic brain injury patient may be okay, but subsequently you would see there will be progressive worsening in their clinical condition and progressive deterioration in the CT imaging also. And very often we would attribute this to worsening edema. Yes, there is worsening edema. Along with this, there is a lot of cascading of the inflammatory process within the brain with the release of all these mediators, which leads to perpetuation of the brain injury and worsening of the brain edema. And along with this, it is shown there is activation of these astrocytes and the microglia cells also that happen. And all this injury, the cytokine storm which happens within the brain, activation of these cells leads to alteration in the blood-brain barrier. So the blood-brain barrier gets breached. So this is the sort of a conundrum that one would witness in severe acute brain injury. And along with this, when there is an injury to the hypothalamus, there is autonomic dysfunction that sets in. And this autonomic dysfunction has a role to play in the inactivation of the surfactant production that happens within the alveoli. And there is increase in the pulmonary vascular resistance, and there is capillary hypertension also that sets in. And this increase in the vascular pressure or the pulmonary vascular resistance can be attributed to the autonomic dysfunction that happens when there is an injury to the hypothalamus. So these are all the multimodal ways how the lungs tend to get more severely affected along with the traumatic. So although the injury is in the brain, but there are certain mechanisms that happen which breach the alveolar capillary membrane and the inflammatory process per se secondary to the traumatic brain injury. So we need to understand the brain injury also has some bearing on the lung. And posterior hypothalamus injury is known to increase in the alpha adrenergic component, which also has a bearing on the perpetuation of the lung injury. So this is the sort of physiological understanding that although there is a traumatic brain injury, it has some bearing on the alveolar capillary integrity and the inflammatory process that sets in, and there is increase in the pulmonary vascular pressure also that sets in. So in severe brain injury, it is shown that 40% of the patients with severe acute brain injury can develop ARDS. And this can be due to insult to the lung or primarily due to the brain injury itself because of the correlation of inflammatory process that happen in the lungs. They are at a higher risk of developing ARDS. And the treatment that are instituted for ARDS can have a bearing on increase in the ICP and reduction in the cerebral perfusion pressure. The treatment that we institute for ARDS does have a bearing on the ICP and the CPP. So what about low tidal volume mechanical ventilation? So the challenge of low tidal volume is because we understand when we give low tidal volume as a standard of care for ARDS, it increases the CO2 because you're giving low tidal volume, it increases the CO2 and it can lead to hypoxemia. And these two together, because of using low tidal volume, there is a higher CO2. When there is higher CO2, it has a bearing on increasing the ICP and it reduces the brain tissue oxygenation also. So that's why the low tidal volume mechanical ventilation, which is a standard of care for ARDS, can have detrimental effect on the ICP. So, and our understanding is when we so when there is increase in the tidal volume, so of more than 1.3, so the odds of developing ARDS is 1.3 for every ml increase in tidal volume more than 6 ml per kg. So because in ARDS we maintain 6 ml per kg tidal volume, so every 1 ml increase more than 6 ml increases the odds of them developing ARDS by 1.3. So, that is a problem we have when we are dealing with traumatic brain injury, because we cannot give higher tidal volume. And we know the ARMA trial has shown that the low tidal volume, 4 to 6 ml per kg, what we give in ARDS, there is 9% absolute risk reduction in the mortality. So we need to follow this as part of ARDS, but we understand by using this, it has a detrimental effect on the traumatic brain injury. And ARMA trial also showed using low tidal volume increases the ventilatory free days. So the target that we consider it as something safe is to maintain PaO2 of 55 to 80 and pH more than 7.15 in ARDS. But is this safe for traumatic brain injury? That is a concerning point at this point of time. So the theoretical risk in severe acute brain injuries, when we use this ARDS protocol as per ARMA trial, using low tidal volume and attaining a PO2 of 55 to 80, so that may not be good enough for traumatic brain injury. So when we use ARDS protocol, there is increase in the CO2 and hypoxemia that sets in. And this increase in the CO2 leads to cerebral vasodilation. And this can lead to increase in the intracranial pressure, and cerebral oxygenation reduces when you use ARDS protocol. But to circumvent this, when you hyperventilate to reduce the CO2, hyperventilation also is dangerous. When you do hyperventilation, there is cerebral vasoconstriction. And this, although it reduces ICP, because there is intense vasoconstriction, it can lead to ischemic deficit. So there can be cerebral ischemia that develops when you do hyperventilation. So it is suggested that CO2s cannot be less than 25 millimeter mercury for more than 30 minutes. So when you use ARDS protocol and you tend to hyperventilate to reduce the CO2, that itself can cause harm by causing vasoconstriction and by causing focal neurological deficits, by causing cerebral ischemia. And it should not be kept less than 25 millimeter mercury for more than 30 minutes. So the target has to be that CO2 has to be maintained at 35 to 45, because if you maintain higher CO2 also, it's not good, because it increases ICP by causing vasodilation and cerebral oxygen can come down. So these are the studies which are shown in severe acute brain injury. If PaO2 is maintained less than 110, there is 50% higher odds of patient dying. So this is something new which came out, which at least was a learning point for me. When someone has ARDS with a severe acute brain injury, although the ARMA trial, all those suggest that we can maintain a lower oxygenation, but in like 55 to 80, but in severe acute brain injury, we have to maintain PaO2 more than 110, because these are the three studies we showed. There's 50% higher odds of death when you maintain PaO2 less than 110 in ARDS. So when you see the ARMA trial, it suggests that we can maintain PaO2 of 55 to 80, but that may not be acceptable in severe acute brain injury. So that's a new point that came out of this particular review of this article, that we cannot maintain lower PaO2, because many of listeners and trainees would know that in ARDS for a saturation of 88 to 90 is acceptable. But along with severe acute brain injury, we need to maintain PaO2 of more than 110 is what we can deduce from the studies. So the summary of low tidal volume is low tidal volume mechanical ventilation. You need to strike a balance to make sure that carbon dioxide is not too high. At the same time, there is no less oxygen also. Oxygen has to be more than 110. And the targets have to be individualized if there is any brain monitoring that is happening. So one needs to customize these targets depending on titrating to the ICP and the brain tissue oxygen. So the ideal targets, what is suggested is CO2 of 35 to 45 and PaO2 of more than 102. So this is a new strong message that came through this review, that we need to maintain higher PaO2 even when there is ARDS in patients with severe acute brain injury. So this is something new, I'm sure, for most of the listeners, that we cannot accept lower oxygenation. So how about positive PEEP, high PEEP? Because most listeners would agree that we shy away from using higher PEEP in traumatic brain injury, considering that your cerebral perfusion gets affected and CPP comes down and your ICP goes up. Yes, it is true to some extent, but let us review. So high PEEP, we know it improves the lung oxygenation. It improves the oxygenation in the lung. But high PEEP is known to increase ICP and reduces the cerebral perfusion pressure. So physiology, we understand when you use PEEP, it is with an intent to increase the functional residual capacity and improve the ventilation perfusion mismatch. And we use high PEEP to recruit the collapse of alveoli and to prevent the collapse of these alveoli. So PEEP optimization typically in ICU in ARDS we do using the titration table, or we titrate PEEP based on the transpulmonary pressure by using esophageal manometry in some cases, or we optimize PEEP based on optimizing of the driving pressure, which is plateau pressure minus PEEP, or we do PEEP optimization by the flow volume loop. So any of these methods we would traditionally use to optimize PEEP. But when you use PEEP in severe acute brain injury, it increases the intrathoracic pressure. So increase in the intrathoracic pressure reduces the venous return in the brain. So it impedes the venous return. And this impeding of the venous return in the brain increases the ICP and it reduces the cerebral oxygenation. And it is shown that when the autoregulation is intact, so there is vasoconstriction with increased ICP and reduction in the cerebral oxygenation with increase in the PEEP. But when autoregulation is impaired, then there is this typical thing that happens. There is vasoconstriction that happens, reduction in the CPP, and because of vasoconstriction, there is this ischemic deficits that develop. So which means giving high PEEP has a diabolical effect, because you need to understand here for all the trainees, whenever there is severe acute brain injury, there are two components in the brain. One aspect is in 50% of the cases, autoregulation will be intact. So the PEEP has a different effect where autoregulation is intact. There is vasodilation, increase in the ICP and reduction in the cerebral oxygenation. But more than 50% of the patients with severe acute brain injury, autoregulation is impaired. When autoregulation is impaired, then there is more vasoconstriction that reduces CPP, and because of vasoconstriction, there is ischemic deficits that happen. So the PEEP has a diabolical effect on the brain. This is something which trainees should appreciate, that in brain injury, there are two different mechanisms that can happen. In brain where autoregulation is intact, the effects will be different. In situations where autoregulation is impaired, the effects are little different. So it is shown, this is a study which showed that PEEP in more than 50% of the patients with severe acute brain injury have impaired autoregulation. So that is something we need to understand, which means if you give higher PEEP, it causes more vasoconstriction, reduction in CPP, and it can cause ischemic defects in the brain. But what has been shown from the study from this US group is, although this has a diabolical effect, but it was not shown to have clinically significant benefits as long as PEEP is less than 14 centimeters of water in severe acute. So all the changes, all the diabolical detrimental effects happen only when you give much higher PEEP of more than 14. So less than 14, it is shown that no clinically significant effects happen. And even this study from Germany said that 12 centimeters of water of PEEP is considered safe, and there was no significant effect in the change in ICP. So what we can deduce is 12 and less than 12 is something safe in patients we could use in ARDS even with severe acute brain injury. So that is the strong statement that came out in the review, that less than 12 centimeter of water or 12 less than or equal to 12 is something we can go up to even with severe acute brain injury, because studies have shown there is no change in ICP when you use that PEEP. So what about recruitment? So recruitment, we know we use a much higher PEEP. So recruitment maneuvers are used as a salvage measure in ARDS to open up the collapsed alveoli. But we know when we do recruitment maneuver with a very high PEEP of 25 to 30 or 35, it can cause hypotension. And we know in traumatic brain injury, hypotension is very bad, because hypotension can have hazardous systemic and cerebral hemodynamics. Because we know when we do recruitment, patients can get hemodynamically stable, they'll be reducing the venous return, and they can dump the blood pressure. And this is not good for traumatic. Because traumatic brain injury, we cannot allow to patients to have hypotensive episodes. So, and when you do recruitment, because of hypotension, there can be reduction in the CPP. And the randomized controlled trials have shown aggressive recruitment with high PEEP. In fact, this is a study which came in JAMA in 2017. We show that high PEEP recruitment has shown increase in mortality, can cause hemodynamic collapse and barotrauma. So the evidence is when we use recruitment with 25 to 35 centimeters of water of PEEP, it is shown to increase ICP and reduction in CPP. So the conclusions one can make is recruitment maneuvers with PEEP more than 20 should be avoided in severe acute brain injury. So we saw in the previous slide, up to 12 PEEP can be safely used, even up to 14 if it is as a salvage measure one could do. But beyond that, it can cause significant increase in the ICP and reduction in CPP, and recruitment maneuvers ideally to be avoided in severe acute brain. So how about pulmonary vasodilator therapy? So pulmonary vasodilators like prostacyclins or nitric oxides have been used to improve ventilation perfusion mismatch and to improve hypoxemia. But the problem with using pulmonary vasodilator therapy is it inhibits the platelet function. Any of these agents, prostacyclin can cause or prostaglandins can cause inhibit the platelet function, and it can have synergism with P2Y12 inhibitors. So there are case reports which have shown that usage of vasodilators has shown to improve ICP and brain tissue oxygenation. But again, by using this, the case reports have also shown that these vasodilators can cause hypotension. See, one key thing we need to understand is we have to maintain 7 normals. We have to maintain normovolemia, normotension, normalcia, normalcardia. All these are very important. So we cannot allow hypotensive episodes. And use of vasodilatory therapy has also shown to worsen the bleeding aspects within the brain. So the summary of the conclusions that we can make is there is limited data with the use of vasodilators in ARDS when there is a concomitant severe acute brain injury with regards to safety and its benefits. So to be avoided as much as possible, use of vasodilator therapy for ARDS when there is severe acute brain injury. So that is something one can keep. So recruitment maneuver to be avoided, vasodilator therapy also, there's not much data. Okay. What about fluid management? So the challenge with fluid management is we understand now that the conservative fluid management is here to stay because we don't want to over-resuscitate. Even if you resuscitate, we need to do de-resuscitation and maintain net neutral balance. So conservative fluid management is here to stay, and conservative fluid management is shown to reduce duration of mechanical ventilation. But when we say conservative fluid management with traumatic brain injury, it doesn't mean we can cause hypovolemia. Because if you cause hypovolemia, it can reduce CPP. But on the same note, if you give aggressive hypertonic saline treatment, it can increase the volume and it can lead to deleterious effects. So the physiology of using hypertonic saline is you increase the tonicity within the intravascular volume so that it pushes the edema from the cells into the vascular component, or it pushes the water from the interstitium into the vascular component. So that is our understanding, and thereby reducing the ICP. So this is our understanding of using hypertonic saline. So what is the evidence? The FACT trial, which we all know in patients, has shown conservative fluid management increases the ventilator-free days and improves the gas exchange. So that's why we tend to maintain euvolemia or a little bit on a drier side in ARDS. But using lesser volume or euvolemia is good, but hypovolemia is definitely not good for traumatic brain injury because it reduces the cerebral perfusion pressure. Although FACT trials said by keeping them on drier side improves gas exchange, this cannot be adopted in severe traumatic brain injury. So because euvolemia is needed to maintain CPP, hypovolemia reduces the CPP, cerebral perfusion pressure. And hypertonic saline, one has to be careful, especially when someone has a concomitant CCF. And mannitol, one needs to be using in caution because there is a risk of worsening AKI. So this is about something one needs to keep in mind. So the summary is whatever fluid you give, it is to attain hemodynamic stabilization. And after the hemodynamic stabilization, your intent of giving fluid is to maintain euvolemia, to maintain cerebral perfusion pressure and cerebral oxygenation. So hypovolemia to be avoided, and hypervolemia also to be avoided in traumatic brain injury with ARDS, because hypervolemia is bad for the lungs. So euvolemia is the way to go. And when you are using hypertonic saline, so be cautious of increasing the intravascular volume status is what the message that came through. And most importantly, avoid hypotension in TBI and maintain good CPP in subarachnoid hepatitis. So these are the take-home messages that came after review with regards to fluid management when there is concomitant ARDS and severe acute brain injury. What about steroids? So because we understand that steroids, especially in COVID, it was shown to be helpful in ARDS in reducing the lung inflammation. But steroids are shown to increase the vasogenic cerebral edema. So it does increases the edema in the brain. And steroids have clearly shown to worsen the outcome in patients with intracranial hemorrhage, or in patients with stroke, or in patients with traumatic brain injury. Steroids have shown to worsen the outcome. So, but here we see in ARDS, steroids have shown to have beneficial effect in some of the studies. So there was a Spanish trial in ARDS which showed dexamethasone had a favorable benefit. So steroids are coming back in ARDS, but steroids are known to increase vasogenic edema and are shown to worse outcome in intracranial hemorrhage, trauma, traumatic brain injury, and the stroke as well. And corticosteroids are an independent risk factor for ICU-acquired weakness as well. So steroids also are diabolical. So although you may be using steroid to protect the lung, but it is not safe in these brain edema issues. So summary is corticosteroids are beneficial or may be beneficial in ARDS. So one has to weigh the risk benefit when you are starting steroids for ARDS, keeping in mind that steroids can worsen the edema, and studies have shown it worsens the outcome, especially in traumatic brain injury, stroke, or in the cerebral hemorrhage. So if ARDS is more severe than brain injury and you have to save, then maybe short course of steroids one could justify. So the risk benefit balance is what one needs to ascertain when it comes to steroids. What about prone position? So this is an interesting. So one new message I'm sure for all listeners is when there is ARDS with traumatic brain injury or severe acute brain injury, we need to maintain high PO2 of more than 110. In prone position, there's an important new message that came. So the challenges in prone position with in traumatic brain injuries, it does increase ICP. When you put someone in prone, it is shown to increase intracranial pressure. Along with this, there can be a lot of dislodgement of the drains that may be present in the brain, or the ICP monitors can get dislodged. So there is dislodgement issues and logistic issues. And it is also shown once you put the patient in a prone position, there can be compression of these neck veins, and there is impeding or inhibition or of the venous return to the brain also that tends to happen. So the PROSEVA trial, which most intensivists would have heard, has shown that prone position is helpful in saving lives because there was a mortality benefit when someone was put in a prone position for more than 16 hours per day. But the evidence with regards to proning the patient in severe acute brain injury, that evidence is not clear. In severe acute brain injury, someone develops ARDS, we don't have strong evidence. But what has been shown is even if you prone, it is suggested that one needs to put in a reverse Trendelenburg position or head-end position, so, or a reverse Trendelenburg position. And there is a study which shows that the change in ICP and CPP when you put in prone was not significant. Even if you put in prone in a reverse Trendelenburg position, the change in the ICP and CPP was not found to be significant. And there is an alternative strategy that they have come out with because proning is difficult in traumatic brain injury. This is interesting for all the listeners. It's called supine chest compression. So this is something which was new to me also. So the alternative strategy is putting the patient in a head-end. So this is a traumatic brain injury. Put him in the head-end position and put a weight on his chest. So they put a weight on his chest. And when you put a weight on the chest, this is called supine chest compression. You're putting a, so there is change in the chest wall elastance that happens because your chest has to move against the resistance. So there is change in elastance of the chest wall. And there is redistribution of the tidal volume and PEEP to the dependent part of the lungs. That happens when you put the patient in a supine head-end elevation with a weight on it. And this weight is suggested has to be kept for 8 to 12 hours. And this weight you can keep it with a fluid bags or a sand bags, or the saline bags can be put on the chest. And there is interestingly a trial that is happening in USA with regards to this supine chest compression. It's called Alter Prone trial. So I'm sure many listeners would want to know how much weight to keep. So the weight they're using in this Alter Prone trial is 100 grams per kg. So if it is 60 kgs, so you would keep 6 kgs on the chest for 3 hours. If it is 70 kgs, it's very easy. 7 kgs you have to keep on the chest for 3 hours. So this trial results are still not out. It's a randomized trial that is happening. We are called an ultrasound trial. So all the listeners watch out for this trial if it comes out. The inclusion trial for this is patients with traumatic brain injury with ICPs more than 30 millimeter mercury who cannot be prone, and CPP of less than 60 millimeter mercury. It means they have taken severe acute brain injury who cannot be prone and who have developed ARDS for this trial, which is a beautiful trial if it comes out to look into whether this had a beneficial effect. And this is a picture of a patient where they put the saline bag or sand bag over the chest. So remember, it's 100 grams per kg. One could remember as a modality if you wish to do, if you are dealing with a severe acute brain injury with ARDS, this is something one could consider. So that's about prone position. Some interesting insights, new insights about supine compression. So now we'll talk about the last bit, which is extracorporeal membrane oxygen. So all the listeners would know the Caesar trial, which came in Lancet in 2009, showed that patients with ARDS, when they're sent to specialist ECMO center, they had a higher survival rate and reduction in the 6 months disability. Then the EOLA trial came. So this EOLA trial, which came in 2018, did not show any outcome benefit. Primary endpoint, there was no benefit with ECMO, but there were benefit with regards to secondary endpoint. So there was reduction in the treatment failure, there was reduction in the need for renal replacement therapy, and there was reduction in the need of prone position. So in that sense, patients with ARDS, ECMO has shown to have some benefits. But how about in traumatic brain injury? It is shown that putting traumatic brain injury patients on ECMO increases the ICP, and it can cause intracranial bleed, and it can cause to a lot of ischemic deficits in the brain. And ECMOs, because you put large vein cannulations, so it can impede the venous return to because you would putting a IJV. So it is suggested that more of femoral veins have to be used so that the venous return to the brain is not impeded. Because when you use ECMO, the venous return to the brain can be impeded when the neck veins are used. So there are sort of a case reports that have tend to use ECMO without anticoagulation. With modified anticoagulation techniques, they have tried to do the extracorporeal, and they have even tried pumpless extracorporeal lung assist devices have been used. And these are all in the evolving phase. And there are case reports that has come from Germany where they showed modified anticoagulation, which has been used in patients with traumatic brain injury and ARDS needing ECMO. So there are case reports saying that ECMO can be performed even with traumatic brain injury by not using heparin, by using other alternative methods or modified anticoagulation to reduce this worsening of the bleed in the brain. So this is something that they have used. And even there is one case report where they have used ECMO. They have done decompressive craniectomy for patients who are on ECMO. So that was a case report from USA. So right now the evidence is limited to case reports and case series. And if someone develops traumatic brain injury with ARDS needing ECMO, possibly they need to be handled in a ECMO specialist centers where there may be a lot more expertise. But the key aspect is to try and avoid using anticoagulation or anticoagulant-free techniques is something. Like citrate or something of that sort should be considered to maintain the extracorporeal circulation. Otherwise, there is no strong evidence of routine usage of ECMO, especially in patients with traumatic brain. So that comes to the end of the review of this whole topic. So the key take home is low tidal volume, you can use it, but obviously you have to maintain the balance between rising CO2 and avoiding hypoxemia. And the key aspect that came out very strongly is we have to maintain PO2 of more than 110 in ARDS. That is the key thing. And with regards to PEEP, the take-home message is you can use PEEP up to 12 very safely, even in severe acute brain injury, because studies have shown there is no major change in ICP or CPP up to 14. So 12 is something that you can use. With regards to recruitment, there is no safety because we cannot use recruitment because you use high PEEP, it reduces ICP, reduces CPP. If you have to use it as a salvage, go only to 20 of PEEP, not more than that is what came out of review. And vasodilatory therapy, again, there is not much evidence. So, and there are safety issues with regards to bleeding because it interferes with the platelet function. And what interestingly came out was a prone position, because prone position we saw there is a supine compression which can be used as an alternative. That is new for me also. That is something which is very new for all of us. There is alter prone trial that is happening. So we all have to watch out. But if you have problem with proning, we can consider using it. Is a good sort of a message that came out. And then steroids are sort of harmful for traumatic severe brain injury. If you have to desperately use for ARDS to reduce inflammation, you have to weigh the risk-benefit balance. And with ECMO, there's no robust data available. ECMO with TBI with ARDS, but there are case series and case reports. So that's the end of it. So thank you one and all. So I end with this beautiful quote. So I never lose, either I win or I learn. So thank you all.